Hello. Wow, 16 of you already watching. Fabulous. Welcome to another Vulval Pain Society. This is a research special. Well, it's a little bit more than that, actually. Thank you for joining us live or on the replay. Please say hi in the comments. I just want to know that you can hear me okay. Let us know where you're watching from. And you can pop in questions as you go along today, any comments in the box as we go along. So just say hi in the comments if you can. Can't see any comments. I hope you can hear me. Oh, hello. Hi, Joanne. Okay, fabulous. I'm assuming you can hear me, Joanne. I can see there are 25 in the room. Fabulous. Hi. I am Sheren Gaulbert, Vulval Pain Society Trustee. If you've watched before, you'll know that I have a past experience with vulval pain. It's with my pain therapist, clinician, coach, pain science education hat on that I met today's phenomenal guest. We are ready, aren't we? We're just going to go ahead. Hi, everyone. Hi, Pauline, Joanne, Catherine, Petra, Lydia. Thank you all so much for joining us. Our guest today, the wonderful JILLY Bond. Let's make this look a little bit prettier, shall we? There we go, up close. Hi, JILLY, clinical specialist, pelvic health physio, co-director of the Pelvic Pain Network, which we'll discuss a little bit later on in today's live stream. And excitingly, what we're starting off today, you're a doctoral researcher. And first of all, before we get into this, JILLY, we met some time ago.
We did.
Some people watching, they might not know who you are, which is going to be weird to me. But tell us, JILLY, a little bit about yourself, how you came into working in this area in the first place, and now, you know, this research area you've got going on, and some of the roles that you've played in this pelvic pain sort of arena.
Thanks, Sheren, and thanks for that lovely introduction. I was trying to think back. I think we met at a conference. Oh gosh, in 2016, 2017? One or two. Yeah. I can't remember. Yeah, so I'm JILLY. I'm a physio based in South Wales, and I specialise. I'm a pelvic pain specialist. So I've been a specialist in this area about 16 years. I qualified as a physio and went to work in the NHS and had a lovely time and rotated around everywhere. And at some point, they were really lacking in women's health physios, as they were called. So I was kind of popped onto that as a rotation, trained up, and found my calling. There's something about having this beautiful space that you can hold for a woman who is going through prolapse or incontinence or all of these terribly embarrassing, terribly difficult to talk about issues. And then my job was great because I kind of got to fix them without hurting anyone, which was great. So I absolutely loved women's health. I loved the connection that you got with someone as quick as possible. And then over time, I became more and more fascinated by pelvic pain. In 2014, I think it was, I did my master's looking at pelvic pain, specialising in bladder pain syndrome. And that was really spurred on by a patient of mine who my understanding wasn't there, and I was challenged to try and understand what was going on with her and how we could make real improvements to her life. She was a nursery nurse. She couldn't keep popping to the toilet every 20 seconds. She was in a huge amount of pain. It ruined her life. And the research wasn't really there. So I went and had a look at some stuff. I did a little research trial using some data because my NHS trust at the time would not allow people to use pelvic wands. Because they felt there was no safety data, but we were also only seeing people every 6 weeks. And from a physio point of view, that was pretty crushing because we needed to be able to follow up. We could see people would get a bit better seeing us, but if we could only see them every 6 weeks, that was terrible because there was just no progress made. So I did a trial to look at the safety and feasibility of using wands, and the outcome of that was that now they're safe and effective, and the NHS can prescribe them in the UK. And we know that actually if we can only see people every 6 weeks, if they can do effective therapy in between times, brilliant. But moved forwards from that, because it's not all about the wand, as one of my YouTubes goes on about, and we use a lot of other devices and techniques these days. But I just stayed interested in pain. there wasn't really much going on in the world of pelvic pain in the UK. So I started teaching some of the findings that we had from the research we'd done, and developing research connections through conferences with lots of lovely people like yourself, and became good friends with Dr. Judith Thompson and Carolyn Van Dyken in Australia and Canada. And we've been doing a series of kind of interventions and research groups with some master students through Judith, who works at Curtin University in Australia for a couple of years. And I very gently got bullied into doing a PhD because we didn't have answers. And there's things that we've been looking at for 10 years that I'm finally trying to get answers for. And it's really fun because I'm lucky to be surrounded by lots of really formidable, fantastic women who also work in research that want to find the answers. So there's quite a big group of us that are moving forward in this area. So that's where I am. Yeah, we're 2024, and I'm a doctoral researcher at Brunel. I work 2 days a week. I have 2 sessions in clinic, still seeing women in South Wales, and I'm a co-director of the Pelvic Pain Network, which we're going to talk about later. But yeah, life is flexible, shall we say?
Yeah. And I know you've got some slides to take us through before we go into the Q&A. And are you happy for people to wait until the end to ask questions or ask as we go along? Would you prefer?
I don't mind answering questions at any point if things pop up. It might make more sense to answer as we go along. But hello, everyone. I'm really happy to see so many of you have come over to have a look at what we've been doing research-wise in vulval pain in our little corner of the country.
So I'm going to remove myself, and if you want to add your slides in.
How do I do that? Present, slides, here we go. Nothing happened. You've
gone into slides. I'm just going to talk Jilly through this. We should have practiced this. You got into slides. Can you see your slideshow?
Yeah, it says present slides. I click on the slides.
Yeah, that's fine. And you should be able to see it at the bottom.
Yeah.
And in the middle of that, it says add to stage. Click on that and it will just add it to the stage. Just move your cursor over it.
Yeah, it doesn't say that, Sheren, sorry.
Okay, shall I add them? You might have to go. Next slide, please.
That's fine. You can be my my mouse. Thank you very much, Sheren. Okay, so this is me, and this is sensory. We're going to be talking about sensorimotor distortion, which is the area of research that we're looking at. Could I have the next slide, please, Sheren? Thank you, Sheren. So we know that around about over a quarter of the world's population experience pelvic pain at some point in their life, which is a pretty shocking statistic. And that covers persistent pain, which would be things like vulvodynia, provoked vestibulodynia, those conditions where you have a pain on most days, to pains that are cyclical, things like endometriosis, where you might have really bad pain around your period, or dysmenorrhea is another a term for really painful periods. And we diagnose that if you've got pain that goes on for 3 months consistently, or 6 months cyclically every month. And along with that, we get lots of issues concurrent with the pelvic pain, which can include things like anxiety and depression. And we now understand that that's actually a part of the condition, an effect of the condition, but also part of the pain state, and shouldn't be looked at separately from it. So we're kind of in that zone. Next slide, please, Sheren. Thank you. Within physiotherapy, we have lots and lots of things that we can do to help pelvic pain. So our 3 goals are to normalize your pelvic floor function, because often by doing that, we can actually change pain, and we can also restore your normal functional activities. You can go to the shops without having any incontinence or any pain. You can have a poo and a wee and it doesn't hurt. We also want to normalize that organ function. So we want to make sure that your bowels and your bladder are working effectively, and we want to restore that quality of life. And we know that pelvic pain significantly strips back your quality of life. It's from the little things, from not necessarily being able to wear pants or clothes that are tight, to not being able to go out for dinner and sit down. And that means that you're not socializing and doing all the things that you want to do. All of the things in green around those 3 goals are pretty well evidenced and researched in physiotherapy, but graded sensorimotor learning is one that isn't so far. And that's what we're looking at. And that is the approach of trying to restore some of the sensory functions of that area. So what you feel, and that can be things like pressure, movement, soft touch, heat, cold, and also the motor elements, which would be things like the pelvic floor moving. Is it relaxing enough to be able to have a wee or a poo? Is it tightening when it needs to store, or is it just kind of stuck? So we're trying to look at ways that we can evidence that, because we don't want to be doing something if it's not actually useful. And in physio, we do these kind of elements of sensorimotor training in lots of different areas, because we think they're useful and they've proven useful in other areas. But in pelvic pain, we haven't really looked at that yet. Next slide, please. So the idea of sensorimotor learning or training is built on ideas of body perception. Now, your perception of your body is really dynamic. It changes from moment to moment, depending on if you've just eaten, if you're more bloated, less bloated, and also on how your body systems are functioning, and therefore how they think they are doing. So our predictions about ourselves. If we are tired, our predictions are going to be slightly different to if we've had a really good night's sleep. And that prediction and that dynamic change in how we feel about what is happening in our body and our brain's representation of that is based on our senses. So the feelings that we get from the area, and the feelings and the awareness that we get from our insides, so kind of awareness of bloating, we call that interoception, and proprioception, awareness of what's happening on our pelvic floor. And all of that information comes up into the brain and to the spinal cord, and then you process it, and you process it in the tissues, and you kind of work out what you think is going on with your body. We also base our kind of sense of our body, or a body model, or a sense of self is built on how we interact with our environment. So I'm sat on a swivelly chair, and I can feel the chair beneath me. And so my interaction with the chair gives me an idea of how big my bottom is right now. Yeah, and it's our interactions with the environment which allow us to build that sense. Next slide, please, Sheren. But that can go wrong. So sensorimotor distortion is when there is a disruption, or it goes wrong basically in our sensory function of the area, or our motor function. And that means that we don't necessarily have a correct or accurate model internally of our size, our shape, and how our tissues are functioning. So if some of our sensors are either a bit too active, so they're a bit hyperactive, and we're very hypersensitive, we may perceive that our tissues are actually sore or tender, or that they aren't as, they're a bit more, vulnerable. Yeah, and that's often what a vulva feels like. It feels really sore and tender, and like it's going to tear, or it's too dry, or we can't take contact with things. And that could just be, it can be a tissue thing. There are lots of reasons for pathology, but it can also be a wind up in those, a change in the kind of sensors within that area, or a change in how those sensors, the information from those sensors is processed. All of that can lead to changes in how you feel about yourself, and how you process what is going on with you. Next slide, please. So we see this kind of dysfunction or distortion in our sensors and our motor, so our muscle movement, and our ability to move our muscles as we want to, with finesse and accuracy. We see it in other areas. So we see it in CRPS, which is complex regional pain syndrome, which is often a condition people will get if they have a hand or a foot or a leg operation, and seems to be that the body has a massive response to it that we don't really understand why, but they have all this huge amounts of pain. They can't even take a kind of a sheet lying over their foot. It's really, really painful. Even thinking about moving it is painful. And we also see it in low back pain. And those changes in the sensory motor function are changes in how big they think their back is or their foot is. It can be bigger, it can feel smaller than it actually is. They can be not really very good at working out if someone's touching them and where they're touching them. So that sense of proprioception, or what we call tactile acuity, accuracy and where you're being touched, is off. They don't really know what kind of sense is touching them. Is it a hard? Is it sharp? Is it deep? Is it blunt? And they're also not aware of being able to propriocept. So that unless you tell them or you show them in a mirror what position to be in, or ask them to be in a certain position with their back particularly, they can't get themselves into that position because they kind of don't know where it is unless they look at their back. We know that that goes on in other areas of the body that are in pain for a long period of time. So our thought is, does this happen in pelvic pain? Because if it does, then that's something that we can try and change. And if we can try and change it, it might change people's pain. Next slide, please. So the answer is, we know that there are dysfunctions of the sensory apparatus in pelvic pain. And this is only some of the evidence, but we get allodynia, which is where pain shouldn't exist. So in provoked vestibulodynia, which is that PVD, we get pain where pain shouldn't exist, so on soft touch. And some of you might have had that test where they take a swab, like a cotton bud, and they touch your vulva, and it really, really hurts. That is an allodynic response. So it really shouldn't hurt if you touch anywhere with a cotton bud, but that skin becomes super, super hypersensitive. We also get a change in the pressure sensation down there. We know that, and this is on lots of different things. This is only a small nugget of the evidence, but we know this happens in lots of different vulval pain states, and also in people that have chronic or persistent pelvic pain, that if you press, it feels a lot more painful than it should. And the point at which it becomes painful when you press someone hard is reduced. So it doesn't take much for it to feel painful, whereas it shouldn't. You know, if you press your thumb hard, it takes quite a while before it becomes painful. You have to be quite deep. But that, if it was a particularly sore area, it wouldn't take much. And we get changes in thermal perception. So hot and cold feel different. And some of you might know that. A lot of people tell me, I just can't, I want to have a bath, but it can't be too hot. Or I'll use really hot water because it'll be painful and that'll make it feel better afterwards. So that sense of where normal temperature is and what feels painful as a temperature change can also be off in pelvic pain. But we don't know if that's a pure sensory, if that causes any sensory motor distortion. We just know that those are sensory motor dysfunctions. They're dysfunctions of that area. And the bit that I've not added into here is we also know that there is motor dysfunction. So it's well established in lots of different pelvic pain states, including things like vestibulodynia, the pelvic floor is just a little bit more tense at rest than we think it should be. It's not necessarily the cause of pain. It tends to be a symptom of the pain state. So we see these things happening. Next slide, please. Now, they did a really cool thing recently. There was a really, really cool paper called the Resolve trial, which was over about 5 years. And they took lots of people, 276 people with chronic low back pain who had all these changes, and they didn't really know where their back was. Their pressure was off. They couldn't make it move or do what they think it needs to because it all gets a bit smudgy. And they weren't as aware as, and a lot of them didn't know, they didn't realize they weren't as aware, but when they tested them, they weren't. What they did is they did some really, really simple interventions to try and improve how accurate people were with being able to feel their back, being able to pinpoint where someone's touching them, being able to move it accurately. So not move it more or less, but move it accurately, how much they're being asked to move. And when they did that, they found that the people that were doing that as part of their training had a significantly improved pain intensity at 18 weeks of doing this versus people that didn't. Now, the significant improvement was minimal, but it was a significant difference between the groups. So that's our first piece of evidence that suggests that doing something like this may be beneficial for people that have got sensorimotor changes. Next slide, please. So the first thing for us to do was to find a way to measure this in pelvic pain. So we spent probably too many years. I think that's Judith and Carolyn in the picture with me, I think from 2019. We spent quite a few years over lockdown and beyond putting together the Fremantle Perineal Awareness Questionnaire, which is based on another one. This we call the FreePAC. It's based on the FreePAC, which assesses sensorimotor distortion in the perineal area. Next slide, please. The first 3 questions are about distress or disconnection from that area, which we know can be psychological, but it can also be part of your physical state. And when I've given this questionnaire to people, they often feel a lot better when people are asking them questions and they realize that actually they do score on these questions, that these questions are applicable to them. And to some people, they won't be applicable because not everybody is going to have sensorimotor distortion, and we don't know how many people do. So the first 3 questions are about how disconnected you feel from that area and how distressed you feel about that area. The second 3 questions are about the motor function, so how easy it is to move it, whether you really have to think hard to be able to have a wee, to be able to have a poo, to tighten or relax your pelvic floor, your perineum, or do anything you want to do. And the last 3 questions are about what it feels like. And we put that out, we put it together. There was 5 of us that came together to translate it from the back into the perineum. We brought 14 international experts on board to do what's called a Delphi study, where over a series of months and kind of coming together and talking about it, we worked out what was important and how to ask the questions and where the issues were. And they came up with this. We put that out to be validated with patients. I think it was about 135 people, men and women, answered whether this was comprehensible or relevant to them with every single question, and it scored really highly. So I think for people in pain, it probably has quite a lot of relevance. And then we tweaked it, given their responses to us, and we sent it out again to another 80 people with pelvic pain. And these are all different types of pelvic pain, from persistent pelvic pain to vulvodynia, vaginismus, endometriosis, lots of different things. And again, it scored really well. Okay, next slide, please. So this is what we're doing, what we're looking at. Moving on from, now we've got this score and we know it is relevant to people in pain and it works. We're now trying to triangulate, but I like to call it kind of like pyridimate. Doesn't really work, it's not a word, on this idea, because it's more than a triangle. The first thing that we've done is a scoping review, which is a bit like a massive literature review, looking at how are we in the research world and in the literature thinking about sensorimotor distortion in persistent pelvic pain. And we found some surprising things, which we're still in the process of about to kind of dissect properly. But it's really heartening to see there's actually quite a lot of work in dysmenorrhea. And that made me feel really good, because dysmenorrhea, so having painful periods when you start your periods onwards at any point, but having regular painful periods, is we know it's a potential risk factor for developing things like vulval pain. And so it made me really good to know that actually a lot of research is going into the precursors. And if we can understand why people are having pain during their periods that is more than a 4 out of 10, if you're going to give it a number, if 10 is the worst pain in the world, if people are looking at exploring that, that's really good. Makes me feel good. But there was lots and lots of different exploration. We've got about 130 papers across every type of pelvic pain in cisgendered women, and we're looking at the data at the moment. The next thing that we're going to be doing is an online cross-sectional survey using that score. So we're going to put it online, and we're going to ask everybody who is a cisgendered woman. So you identify as a woman and were assigned female at birth, to answer it, whether you've got pelvic pain or not. And we're going to get what's normal for a FreePAC point of view, and we're going to get lots of lovely information hopefully from women with lots and lots of different types of pelvic pain. So we can answer questions like, are you more likely or less likely to get it if you've got vulval pain than endometriosis? Do people with adenomyosis have motor changes? Do they report that actually they can't make their pelvic floor work, or do they have more dissociation? Do people with vestibulodynia have a larger, is there a larger population of people with vestibulodynia that have sensorimotor distortion? Or actually, is it very little? Which would be, surprising, because we would expect the pain states that affect more of the vulval and the perineal region to potentially have more changes, but we don't know. And this is what we're going to try and work out. And it may come down to actually within every single type of pelvic pain, there is a spectrum, and some people have more symptoms of sensorimotor distortion than others. And that's really interesting, because then we're going to drill down on that data and we're going to say, right, for those people that do have more of these symptoms, that it just doesn't feel right. It feels asymmetrical. I don't feel attached to it. It doesn't feel like it's mine. I can't make it work. It doesn't feel right. For those people that have those symptoms, do they have other symptoms alongside that? So we're going to put up a questionnaire around distress and anxiety, which is not to blame people, but just to say we know this is part of the condition. And are there interesting correlations that we can find to do with whether they are a first or second generation with pain, how long that they've had the pain? If you have pain for longer, are you more likely to get these kind of symptoms? If you are taking more or less, fewer medications for your pain issues, are you more or less likely to get these symptoms? So we're hopefully going to be pulling out lots and lots of useful information. This questionnaire is going out internationally. I'm partnered with both Brunel, University of London, and University of Western Australia for my PhD. But we're hoping to go out completely internationally to all corners of the globe and get as many women as possible answering the questionnaire, even if they've got no pain, just to really to give us some good baseline data. Once we've done that, we're going to invite people that have had significant symptoms, that really have lots of these symptoms, into more in-depth discussions about what it's like to have those symptoms. What does it feel like? And to try and understand it a bit more, to understand the impact it has on their lives a bit more. And we're going to get lots and lots of rich data. And from that, we're going to do our final study, which will be some form of integrated lab study. Ask me in 3 years' time. Probably validating the free pack. So using the questionnaire, getting people to fill out the questionnaire, and then do some kind of simple tests that can be done in clinic, so that we could see if we could use this questionnaire a bit more usefully, quickly in clinic. For things like if someone, so I know a lot of my patients that come in with vulval pain, it is just too tender to even begin thinking about doing an assessment, and it would be cruel to do that. So I use the free pack because I've got it and I'm interested in this area, and that means I can understand really quickly, and we can start looking at other things they can do themselves that are not painful, because physio should never hurt. If a physio treatment session ever hurts, then I would suggest that it's possibly not the session for you. So we want to look at whether we can use this tool instead of other things to diagnose. If it's a useful tool to phenotype, which is basically a complex word for saying put things in a box, because we know if we put all the same kinds of people in one box, then we're more likely to treat them with a more of a specialized way. We're going to be better at treating them if we get the same kind of people together and we do studies around the same kind of thing. So that is our hope moving forward. Yeah, I've got another kind of 4 to 6 years working on this, but I am sure to keep you updated. Keep your eyes out for the questionnaire when it comes out. I will be all over my social media, so I'm at JILLY Bond Physio on Instagram, at JILLY Bond Physio or JILLY Bond Physiotherapy on Facebook. I'm on X, the Twitter formerly known as, anywhere else. So yeah, that's the kind of things we're looking at. At the end of the day, if we can get a grip on what the problem is, we're more likely then to be able to design interventions to see how we can treat it effectively. And that's where the fun starts, because that's all the stuff that we're kind of doing in clinic anyway, and we're muddling our way through. We're going to be much more effective at doing that. And my biggest hope is that we're going to come out of this series of research papers with some guidelines for clinicians, which will talk about ways to assess that don't necessarily induce pain in patients. And secondly, we're going to have the potential for the development of treatments, again, that don't induce pain. Because if sensorimotor distortions are a problem in persistent pelvic pain, then we've got a great field that we can start targeting. There are a handful of studies that have looked at this already, but it's a very much the beginning of a field from a physio and occupational therapy point of view. There's some work done in what's called somatocognitive therapy, which are the kind of mind-body therapies that integrate a lot of psychologically informed practice with physio. But we're really beginning. So yeah, the world is our oyster. Is that the saying? I can't think of it. But I'm really, really hopeful that we'll come out of this with an idea of where to go next, and a little bit more of a stronger basis for doing new types of treatments for vulval pain that don't hurt and that don't necessarily, I mean, we need everything. We know in vulval pain we need creams, we need pain relief, we need psychological input, we need medication reviews, we need exercise therapists, we need lots of things going on. We need the support groups, we need the community support. But I'm very excited that this could be a new field for physio to move into as well. So that's all about my research. Do we have any questions about that? Sheren, did you want to pop back in?
There's a question, this may be Catherine in the background actually. Why is the study confined to assigned female at birth cis women?
It's the current study is what I'm going to say. I am very acutely aware of the fact that in medicine, most of our medicine, and certainly the stuff that I have done my learning based on historically, is based on male models that are then put onto the female form. And I thought it was really, really important. We have no data. Yeah, the only data we have is this first validation study of this one questionnaire. So we need some baseline understanding. We need to get a first line data. And when we're doing that, when we're getting baseline data, we need to focus. So we had to choose, and we need to make the field very narrow so we can get some solid data in one gender. And we will absolutely be moving forward and repeating this in cisgendered men, because I think it's really important to get those two baselines and then repeating it in our queer community, so that we can see, is there any element of sexuality that is important at play in this one small symptom? And then again in our transgender community. But I want to protect, if anything, I want to protect our transgender community. And it would be, I think it would be too reckless to go straight into involving them in these kind of studies when we have much more complex situations, certainly in my practice regarding kind of supporting people that have gone through gender reaffirming surgeries, and the impact of sensorimotor change in those particular people is probably quite great, and it's something that we see quite a lot in clinics. So they're last on the list just to be protected, so that we have we don't just go in there blindly and start asking questions, but that we actually have some basis and we can be respectful and we can have already worked out what's important and what's not. So I'm really aware that this is very limited to cisgender women, but we will be absolutely opening up and repeating this again and again to pick out all the nuances that we have in gender declarations, etc.
And important to get that baseline first.
Yeah,
Julie, yeah, absolutely. A couple of things here. What did I see early on? OMG, this might be me. You're giving me vocabulary to describe myself.
Good. I'm glad. I'm sorry that that's you, but I'm also really, really glad that's you've got some words to describe it. Feel free to get in touch. I will be posting kind of copies of the free pack up on my socials tomorrow. So if you need any of that language, just give me a shout. We can talk about it more.
So someone who is booked for a transvaginal CT scan tomorrow, not sure what to expect, already seeing a pelvic physio. Any suggestions, Ginny?
Good luck. I hope it goes well. CTs are CTs. You sit in a tube. They might or might not put some contrast in. So you have, sometimes they do them with like a drip, and the drip puts some fluid in really quickly. It feels a bit weird. You might get a funny taste in your mouth, but it's gone in about 30 to 60 seconds, and they take some quick pictures, and that contrast allows the pictures to have better to look easier to see. Things show up better with a bit of contrast, but sometimes they don't use contrast. CTs tend to be a little bit quicker than MRIs. But I can't give any specific medical advice right now, because without seeing you, and that would be an hour of chatting through absolutely everything. But I would say that my general, what I want to emphasize in vulval pain is that there is absolutely always hope. And in this last 16 years, I can't think of anybody that hasn't made progress. The vast majority of people find a good amount of relief with multidisciplinary therapy. So it's not just a physio thing, but it's getting, the right gynecology, the right dermatologists, colorectal scientists on board, our psychology support, community support, and physio, and getting active. It requires lots of different things, but everybody's different. And it's about finding that right combination of things for you that will help. Actually, what I'll mention now is that we've put together a vulval pain fact sheet with kind of the 5 key areas from a physio, from an evidence-based research point of view that we would want to tackle. That none of this is rocket science, and then are pretty easy and straightforward. So if you head over to the Pelvic Pain Network, so pelvicpainnetwork.co.uk, onto our resources page, you can get a freely downloadable vulval pain fact sheet booklet that will take you through some of these processes, including some of the stuff that we're playing with that will be evidenced, hopefully, through this research and the work that we're doing.
I've posted the link in the comments. Please stay with us for the moment. The links are still going to be there at the end, and we will pop them up again, but they are in the comments. Question here: how would you test for sensorimotor changes generally in the body?
So we would, it depends on how deep you want to. Well, I would take half an hour about it, but you can do it very quickly with a cotton bud. So we would test soft touch, and we would see if someone's got a heightened response. So soft touch with a cotton bud should be, we all know that should feel really boring, as my friend Sandy Hilton says. It should feel boring, just like you're being prodded a little bit, but not painful. But if that's painful, then we know that that's heightened and you have a change in your pressure pain threshold. We can do much more specific stuff with little filaments, which have different amount of pressures on them. But really a cotton bud does to begin with. Then we would test things like hot and cold, if your hot and cold perception is off. And we would also do some proprioceptive testing, so checking that you can feel where we're touching and if that's accurate. So am I on the left side or the right side? Am I on the top or the middle or the bottom? That kind of stuff. And then, do you know the difference between being touched by 2 points or 1 point? Because there is a point in everyone where if you get the 2 points closer and closer and closer, they just feel like 1. And there's a normal score for that. And if you've got a problem with it, you might be touched quite far apart with 2 things, but you can only feel that as 1 thing. So we would measure those kind of things in clinic, and then we'd do stuff, do some exercises, get some new strategies on board, and then retest it. Because it doesn't really matter what the answer to the question is, because that's just like a photograph of today. That is what's currently happening. And if you're less bloated, you're not loaded into your rectum, you're not having a pain flare the next day, your scores will be very different. So it constantly changes. But so what we're looking for is the pattern of change over time with those kind of changes. The kind of things that are seen a lot in fibromyalgia, when people get painful or tender spots in other areas.
And I'm glad you mentioned that context changes things, whether someone has slept well or they're tired, the environment they're in. There's so many things. and that, you know, people with vulval pain often get concerned that they are blamed in some way because they're depressed or they are distressed. You know, that's causing the issue, and that they get blamed that potentially it's all in their head. But you've mentioned that it's part of the pain condition. Can you tell us a little bit more about the fact that it's part of the pain condition?
Yeah, there's a lot of commonalities in persistent pain that we can draw on. That doesn't matter where you hurt in the body, but we know that pain itself is wearing, and pain is draining. And that can have a significant effect on your mood. But specifically in pelvic pain conditions, I'm going to say there's a suggestion, but there's possibly a little bit more than a suggestion. I think my colleagues in the MAP Research Network would say it's more than a suggestion, that we have these cognitive changes. So we have actual structural changes in our brain that co-occur with being in pain for a long time. And those kind of changes that we see, if you scan someone's brain with chronic urological pelvic pain or bladder pain syndrome, also previously known as interstitial cystitis, it looks quite a lot like someone's brain that's got fibromyalgia. Yeah, someone that's dealing with pain all over. And those kind of changes, we think, are to do with the fact that you're having to process a lot of pain, or you are dealing with a threat to your body persistently. And the brain is really good at dealing with multitasking and challenges. So one of the things that Dr. Melissa Farmer and some other people have been working on a long time ago, actually, well, 10 years ago, I think, was some models around the brain changes. And one of them that I like to tell patients that makes them feel more reassured. I actually had this conversation on Monday in clinic with someone and their husband, was that we know that if you're in pain for 6 weeks or more and it's persistent and it goes on, your brain's looking down going, I've got to pay attention. There's something going on. I'm under threat. And if it's in pain for a long period of time, it can't be looking for all of the other threats that are going on. Where are the other bears? Where am I going to be attacked? So it kind of gives responsibility for being aware of your pain state and what's happening in that whole area, in that condition, to your limbic system. And your limbic system is in charge of your emotions. That's your emotional center. So now your emotions are absolutely intertwined with your pain state. If your mood regresses, if you get you're having an awful day, nothing to do with your pain, your cat's run over, your pain will get worse. If you're stressed, your pain will get worse. Christmas happens. There was only one single patient in my clinic, and I have 99% pelvic pain in my clinic of men and women and every gender in between. We had one patient who didn't have a flare at Christmas. We prepped everybody for it. We're like, this is going to happen because it's significantly stressful and your limbic system is hanging on to your pain state. So I would never expect anybody to walk into my clinic that's had vulval pain for longer than 6 to 12 weeks who wasn't tearful or hopeless or feeling helpless or feeling overwhelmed or depressed or anxious. It's structurally part of this ongoing pain. It's different in lots of different people, but it seems to be a commonality that these symptoms express themselves.
Quick one here. Now, it's quite a long question. I'm going to shorten it. It's an 8-year-old girl who had hives in her back and bottom, and she's on a 4 times the recommended dose of antihistamine. Now, the hives is under control, but the vulval pain isn't. And that's come about as a result of the hives. Any advice there? So that's one thing. And they're awaiting a referral to pediatrics, but a possibility that that's not specialist enough. What are your thoughts?
It depends on where you are in the country. There are a couple of really, really good pediatric specialist pelvic health physios. There's one at the Evelina Children's Hospital in London who's absolutely fantastic, Lucia. And there are a few dotted around the country. It's thankfully something that we don't treat very often, but it is something that needs treated. And I had an 8-year-old who had significant vulval pain following an injury recently. We're about 7 months into treatment. She's doing fine. You know, she's no longer having to have Calpol constantly for a poo or a wee. It's you know, she's out, she's back in gymnastics and being able to do cartwheels, which was a very painful movement. I can't give specific advice, but what I would say is that there is help out there, and if you're struggling, please get in touch with me and I'll try and find some people to put you in touch with. That's the whole point of our Pelvic Pain Network, which we'll tell you about in a moment. But there is help out there. It's slightly more challenging with children because we can't do some of the same treatment techniques we would with adults because it's not appropriate, but it's absolutely achievable. Okay, it just you need to look at the symptoms and then just take a step-by-step approach to making sure that the organs are happy, making sure her pelvic floor is happy, making sure her pelvic region, the skin and the muscle and the fascia is happy, and making sure she's happy. I've had lots of chats with this little person that I've been treating recently about feeling safe and what happens if I can't see you anymore. Well, it's all right because mummy can always ring me and things like that. So there is lots that can be done, and that absolutely we have specialists in the UK that can help you treat them. But it's generally a process of making sure first off that we've got really, really good gynae ped support so that you're getting the right amount of pain relief. A really, really good colorectal or gynae nurse, a peds continence nurse, they can be super helpful because they're really good at just knowing the little things that make a vast difference in life for a child to be able to go to the toilet who is in lots of pain downstairs. And we have got the peds specialists within physio, as well as play therapists and all of the kind of from the psychological point of view, because it's a really challenging problem to have when you're little.
Yeah, thanks, Jilly. And now we're going the other end of when we're talking about age. So does menopause make you more susceptible to pain in the vulva?
Absolutely. Absolutely. I am a big I feel like I should be an ambassador for HRT. I send so many people to HRT clinics all the time. You have a vast amount of estrogenic receptors in your vulva and the urethra, so you're more likely to get urinary tract infections, you're more likely to get dry and sore, and that can also be the development of a pain state downstairs, especially if you're dry and sore or just a little bit sore and a little bit itchy. It's not thrush, it's generally genitourinary symptoms of the menopause, which is what we now call it. And if you're not one that's keen for HRT, there's some local HRT. So we're a huge fan in physio of creams downstairs. You can get some estradiol or some Avestin cream, which has such a small, tiny dose of estrogen that you would have to take 365 pills. You'd have to do it for 365 days in a row, put the cream down there, to be the same as one daily dose of estrogen that you would take as proper HRT, kind of with a pill. The dose is so tiny that actually it's now been that NICE have approved it to be on sale over the counter. So simple things like regular use of local HRT, go and chat to your doctor, go and chat to the pharmacist, absolutely get on top of that. And the guidance says it's safe as houses up to, you know, into your 90s. It's not something we need to worry about. So that is a key thing to get on straight away. And I'd like to point out that menopause and perimenopausal symptoms, it's normal for them to start mid-30s, okay? Because if normal menopause is 45 to 51, menopause being the date at which it's been a full year since your last period, somewhere between the age of 45 and 51, and menopause on average, perimenopausal symptoms take 8 to 10 or 12 years before that. If you do the maths, if you're looking at age 45 menopause, your perimenopause is going to start age 35. And that's a common time that we see women, and we endlessly see it in clinic, that have been put on antidepressants, and there is an element of antidepressants that helps chemically with some of the genitourinary symptoms as well as mood, but they're put on antidepressants first instead of exploring hormone treatment. And it is replacing stuff that's gone. So under the age of 51, it is better if you have a low level of hormones. It's safer to be on them than off, apart from if you've got any other kind kind of family history of breast cancers and things like that. So it's really, really worth having a chat with your GP if you're 35 and up and having any soreness downstairs. One of the first things that we always do is get people onto regular downstairs cream for a month, and then review. And I will last week I definitely did that with at least 3 people. I said, right, here's a letter for your GP, let's use some Avestin. And I like the cream more than the tablet because in experience I'm someone that assesses a lot of vulvas, and what I find is that the pills don't dissolve, because if you're putting a pill into a dry area that's meant to dissolve and produce more mucus and normal discharge to help that area, if it's dry anyway, you put a pill in, it doesn't really work that well, because I'm forever still finding them kind of 3 or 4 days later. So the cream we really like because that tends to get absorbed and it moisturizes. So use the cream for a month and then have a review of your symptoms and see what's happening.
We have got questions coming in. How are you doing for time, Jilly?
I'm fine. If you want to keep going.
Okay. So someone who's had a reaction to localized estrogen. Now, this can be a trial and error thing, as we know. So go back to your GP on that one and trial something else. I'm sorry that's happened to you. If it's got peanut oil in it and you have a reaction to that, find something else.
There's about 3 different varieties in the UK. There's 2 that are on easy formulary, and then there are others. So I'd try a few different and make sure that the GP is doing some digging for you. The Menopause Society and the UK Menopause Foundation, I think it is, are really helpful. They've got lots of really good resources.
And I will talk about the library of presentations that we have later on that cover menopause. We cover vulval pain. So some of the questions will be asked in the other videos that we already have. There's one that I just want to talk about before. I know you've got a couple more slides that we're going to get into. Are NHS physios around the UK updated on your research? I was closed by my NHS physio as they said they couldn't help me and they didn't have the knowledge.
So that's a difficult one. I was an NHS physio for 10 years, and I have been in private practice for the last 7. There's a bit of an overlap, I think. Is it 7? So I'm very protective of my NHS colleagues because I think they're doing the best they can with the resources available and the time and the knowledge. What I would say is that you are mandated to do training and updates, and actually there's quite a healthy training schedule within NHS teams that they get exposed to lots of different things, lots of reps coming in, lots of new gadgets and gizmos and devices and information. And there is a really, really active UK national group called the Pelvic Obstetric and Gynecological Physiotherapy Group, which I'm a member of. And I was a prior executive team member, so like the management team of, just for a couple of years. So that's my disclosure. But they are kind of the UK body, and they produce fantastic courses, and they have local regional trainings and lots going on. So there is training available, but obviously it's like anything else. It comes down to what that person is exposed to, how much time that person has time and money that person has to access courses. And a lot of physios aren't supported or paid with leave or paid to do the courses. I've been doing my best to get this information out. I mean, since 2014, 2015, we've trained over 700 physiotherapists in what I call the Happy Bladder course for physios, which is about kind of aspects of pelvic pain treatment from a physio point of view that are evidenced. And we've done that internationally, and it's online. And there's another course for patients as well to directly access the information and the kind of the treatment element of that evidence. So we're doing our best, but it's dependent on different regions and different areas. I'm sorry that that person was told that they couldn't be helped, and that's really kind of one of the reasons why we've developed the Pelvic Pain Network, because as much as I don't want to, I'm not going to blame that physio because they've reached the limits of their knowledge, and that's great. that is a situation that I want everyone to feel comfortable within physio to be able to say, you know, I've got to the limit of my knowledge, but the next step is, let me find you someone who knows more about that area. Because none of us know everything. I'm a complete geek, and I've just been working and looking at this one thing for over a decade, so I know quite a lot about this. I couldn't treat a hand for toffee. So we made the network to get access for patients directly to the experts that treat pelvic pain specifically, and then to link up with everything else. So let me tell you about that. So the Pelvic Pain Network launched in November of last year. We're fresh off the press, and we are a multidisciplinary network UK-wide, so that we're getting rid of that postcode lottery, so that wherever you are in the country, you can book online directly to see a very skilled expert physiotherapist initially about your pelvic pain and any type of pelvic pain. And our team is led by clinical academics, which means people like me that work in research and want to bring that research and speed up how fast that research comes into practice. Because on average it's 17 years, and that's too long. So there's 4 of us in the Pelvic Pain Network that are clinical academics working in different aspects of pelvic pain research in the UK. And we mentor the rest of the team so that everybody is absolutely up to date with the forefront of research. We all head off to conferences and stuff like that together regularly. So you can see someone online generally within a week. You know, we like it to be quick. We like you to be able to have some hope, to have a plan of action, to have a full assessment. And then if there's lots and lots of stuff that can be done online from a physio point of view. There's lots of little tweaks to your bladder and bowel function, to exercises you can try at home. And a lot of the time, unfortunately, we learned through lockdown that we don't have magic hands, and it's about the process a lot of the time. So because we got hundreds of people better during the lockdown just using online sessions. So online sessions go on as much as you want to, or as little as you want to. And if you need to see someone in person, if you're seeing a physio online and they say, actually, I think I really do just need to see what's going on and see if we can get you some hands-on treatment, you can then go and see that person in clinic. So it's what we call a hybrid model, that you can see them online immediately, but then you can see them in their clinic. You can travel to see them if they're kind of local to you, or you can be passed to another member of our Pelvic Pain Network locally that you can have confidence that they are actually going to have knowledge and answers for you. But that's just the physio side of things. As I said, we're UK-wide, but we're also connected with, do you want to go to the next slide, Sheren? Oh, is it going to play the video? It may not play the video. No, okay, don't worry. So we're also connected to about 80 consultants so far, but we're hoping that grows and grows, from every type of speciality, from gynecology to dermatological specialists to, we've got specialist pathologists. I've got a fantastic urogynecologist down the road from me who does a lot of work in embedded or chronic infections, like from a bladder point of view. So we know, because we have those academic links, we've done research with a lot of people, and we spent a lot of time at conferences, we're able to connect patients to the absolute expert they need. And that's always a pleasure, because that kind of bypasses kind of the bouncing around the houses, but actually getting them to the people they need to see. And we're supported by a fantastic support staff of psychological therapies. So we have counsellors, we have psychotherapists, we have CBT practitioners, we have EMDR practitioners, we have lots of different types of therapies, but we also have pain coaches, and we have specialists who will do things around your pain medication and helping you to wean off it. So we're trying to find a really, really simple way that if you log on to the network, you're in pain, you log on, you have an appointment with a physio, they surround you with the team that you need. So not everybody will need all of those people, but some people will. And what we're able to do is put the patient at the centre of that care, be the hub for that person. So I'm sending off letters to the pain consultant to talk about injections for pain relief, or I'm talking to the dermal specialists, I'm talking to the, the pathologists. We're trying to get all of the tests and everything done so that person is supported in their pain and they can make progress quickly, because that's what the research says. And I tried to do it in the NHS, I tried to do it in private practice through a private hospital to make this kind of interconnected care, and became more and more frustrated. So we've now, with my business partner and my kind of co-founder, Virginia Rivers Bulkley, who's based in England, and has been very much at the forefront of the UK's physiotherapy response to mesh, and that's her research. So she's been very involved with helping mesh survivors and looking at how we're going to what the kind of plan for treating them is going to be nationwide and standardizing that. So we really pushed to kind of solve the problem and create that network that we've always wanted to exist. So we're very, very excited that it's now up and running. It is open for business. You can just book yourself on. You can contact us. You can follow us on our social media, which is at Pelvic Pain Network on Instagram, on Facebook. We've got a Twitter, X. And you can see all about what we're doing there and find lots and lots of information. We've been running Vulval Pain basic information this week. We've got lots of resources on the website, including a free download all about vulval pain. Newsletter hot off the press is coming out next week, so sign up to our newsletter if you want to know more about live events. So yeah, that's, do you want to go on to the next one? That's the Pelvic Pain Network. That's how to get hold of us. There we go. That's our websites.
I'm just popping the link up again for and to your website, so that's going up again. Anything else you wanted to mention as people take a picture of that final slide?
I think that the impression that I want people to come away with is that there is lots of research going on in this area. I was at World Congress for Endometriosis in May last year and was astounded and really kind of heartened that people are attacking it from so many different angles. And it's the same in vulval pain. I mean, it hasn't necessarily got the press that endometriosis has, but there is quite a lot of work going on in it. And there is always hope. Everybody's different, and it takes a team around you to make that progress. But it's about finding the right team for you. But again, I struggle to think in my mind of anybody that I've ever treated that hasn't made progress, because it really is something that you can get past, and it doesn't matter if it's been there for 10 years or more. Last week I saw a lady that has had 9 years of vulval pain that we spent last year getting on top of, and she's absolutely fine. She had a little flare at Christmas, because everyone does, because it's stressful. But then she's back on top of it again and is, back to not having any problems. So really there is hope. And there are lots of different people researching and looking at this area. And I'm hoping that the work that we're doing with Brunel and University of South Australia will reap dividends in the next kind of 5 to 10 years in new treatment interventions and kind of pathways for physios in the UK.
Brilliant. Jilly, that was superb. I know we couldn't get through all the comments. There were loads. We will have to have you back on again, obviously.
Anytime.
You are talking about 4, 5, 6 years, potentially more years of research. So of course we'll have you on. And that questionnaire that you're going to share on your socials, we'll of course share that on our website as well. And look, for those of you watching, there's a lot that you packed in the time that we had. And I know we've gone over. Just stick with us. You can re-watch this live stream or any of our previous live streams on our Facebook events page. We will put up a link to that. Actually, I'll just paste that in. Our full playlist of events, now that's presentations, that's webinars we've done, is on our YouTube channel. So I'm going to just pop that up there. And I'll put the YouTube channel one up as well in a moment. Look, we've covered a lot of topics. So you can, and the topics are covered by absolutely the top clinicians and researchers in this field of vulval pain. Like JILLY, we've talked about treating vulvodynia, multidisciplinary care, which is super important, finding that mix of therapies that is right for you, because most people can notice, significant changes as long as they get that right jigsaw of therapies for them, and everyone's different. We've covered preparing well for appointments, because guess what? A bit of prep goes a long way when going to an appointment. Physiotherapy, of course, vulval skin conditions, psychosexual medicine and intimacy with vulval pain, pain science and calming the nervous system, no guesses for who covered that one. Supported self-management of pain, menopause we have covered. So there's a couple of questions about menopause. Go on, and we put them into playlists for you, so you can just go in and look at the menopause playlist or the physio playlist, whatever that you want to have a look at. So have a look at that library. We've got about 45 videos on there with experts. We've covered a lot, so check those out. Now, a couple of points before we finish up, and let me just paste the YouTube playlists on there, and I've just done that. As I say, we've covered a lot of topics. But if there are any expert clinicians or researchers in the UK that you'd like us to have on our live stream, someone you'd like us to welcome back again, even obviously, JILLY, a topic you'd like to have covered, even if we've already covered it, please let us know. Have your voices heard. Give us your requests, because ultimately we're creating these for you. And please bear in mind that we are a small team of volunteers at the Vulval Pain Society. We all work in some capacity in the field of pain with patients and training clinicians. So please be patient with us if you contact us. We may not reply immediately or as quickly as we'd like. We are looking for another volunteer who can take care of our social media marketing. So if you know someone who may be able to help us, so we can ultimately reach more people living with vulval pain, get the messages out, more healthcare practitioners, please get in touch with us or share our details with them. And of course, share our videos, our posts far and wide with anyone you can think of that will benefit or who needs to hear this. We are on YouTube, on Facebook, on Twitter, X, and on Instagram. And listen, thank you to all of you who are already doing that. We are so grateful that you do so. Continue doing so. We don't get around to thanking everyone, but we are super, super grateful, because ultimately we want to help more people living with vulval pain, and the healthcare practitioners and the allied healthcare practitioners who are helping those people living with vulval pain. So last but not least, check out our website. We do have a number of resources on there. So I'm going to paste up that link to our website. So it's there. That is all, unless there's something you want to say, JILLY. I know we've gone over.
Just thank you so much for having me. It's a real pleasure to come and talk to you all. So thank you, Sheren.
Been wonderful, and thank you everyone for joining us today. And I know there are going to be lots of people watching the replay as well who weren't able to make it live, so thank you to you all for joining. Thank you, JILLY, and bye for now. Keep in touch, and we will see you next time. Cheerio.